On this episode, I'm going to be covering in detail the most feared pathology in medical aesthetics. We're going to use a case study to illustrate some of the principles that I believe can make you virtually bulletproof as an injector. Of course, nothing is 100% safe, but I think there are simple things you can do to dramatically lower your risk of ever seeing this happen to one of your patients. So when we think of necrosis, we think about those black areas of tissue where tissue has already died. But why does the tissue die? Of course, when you reduce blood flow to a particular area, it makes sense to us intuitively that the tissue will not keep living. But it's actually much more serious than simply a deterioration in normal function. What actually happens when you have a necrotic wound is that the cells have gone through a much more violent process. The destruction of the cell itself happens down to a lack of oxygen, of course. Oxygen, as it reduces, means we no longer have the single unit of energy that we use to power the cell. The currency, the universal currency, is sometimes called ATP. And the loss of ATP means the cell can no longer regulate itself. It's actually down to the loss of its ability to control its own power that the cell ends up destroying itself. A decrease in ATP means the cell can no longer control its own membrane gradients. So you get an influx of sodium, an increase in water in the cell itself swells, the rough endoplasmic reticulum also swells down to this inability to control ion balances, and this can also trigger an influx in calcium. These processes cause mechanical stress, but probably the most violent thing that happens is when there is activation of the cell's own digestive enzymes. So cells are always breaking down molecules, but in a controlled way and in controlled compartments. As soon as there is an influx in calcium because of a lack of ability to control the cell membrane, you actually start to activate many of the cell's destructive enzymes, and it literally starts to digest itself. Ultimately, this causes a leakage of all of the cell's contents, including all of these destructive enzymes, into the cell tissue, and this destroys some of the neighboring cells as well. It's a little bit like a factory that explodes and leaks toxic waste into the environment, causing damage to nearby structures. It's much more serious than simply slowly dying down to a lack of oxygen. There is much more damage involved. So how many cases of necrosis have I had in my career? Well, the answer is 0. Although I have had a vascular occlusion, it was diagnosed and treated to prevent anything bad from happening. Now, in my clinic, we have multiple clinicians, and over the 15 years we've been running Skin Viva, we have had 27 vascular occlusions. Now, the good news is every single one of those was diagnosed and treated appropriately, so 0 people had a necrotic wound. Necrotic wounds are really what we're trying to avoid rather than simply focusing on vascular occlusion. And the reason it's important to think that way is because you need a different system to prevent necrosis than you do to prevent vascular occlusion. Developing a strategy that prevents vascular occlusion is quite narrow compared with a strategy that prevents necrosis. And this is the key message I'd like you to take away from this particular video. So let's go through the stages that you might see and realize how much time you've actually got to solve each of these problems. The first thing is, how long have we actually got from blocking a vessel before necrosis starts to set in? We know the tissue can survive for several hours after there is no blood supply. We know this, for example, in the case of severed limbs, where reattachment has happened up to 8 hours after a limb has been completely dissected from the body. So this gives us some clue as to how long we have. We also have the example of pressure sores, which are very well studied. So pressure necrosis is slightly different, but if you reduce oxygen supply to next to 0, by creating pressure over a tissue, the earliest sign of a pressure sore developing is at around 2 hours. We also, of course, have many anecdotes of people injecting, diagnosing a vascular occlusion, and then observing tissue breakdown over time. You often see little pustules forming within 24 hours of a blockage. And even at this stage, there are many case reports of clinicians restoring blood flow and getting no necrosis. So I actually think we have quite a long time to get this right, but it's hours and not days. I think if you diagnose immediately in the clinic, you are in the best possible position to do something about it, but only as long as you've injected something you can actually dissolve. So what injection techniques are there that reduce the risk? There is no such thing as an unsafe technique and a safe technique. There are just shades of grey between those two spectrums. And if there's one thing we've learned about other areas of life where safety has been really successful in reducing risk, for example, the aviation industry or in operating theatres generally, it is never just one thing that makes the system safe. So take, for example, the safety step of aspirating. This test has now been proven to detect intravascular placement a high proportion of the time, around about 50 to 30% depending on the paper, and there are many things you can do to actually increase the sensitivity of this test. I think it's probably up in the 80% if you do them all. But this is not enough to reduce your risk to zero. So we need many additional steps to reduce risk, and it's very important over your career to collect as many different safety steps as possible and never to rely on simply one step. If you ever stand over the shoulder of a pilot about to take off with all his passengers on board, they go through a detailed checklist of things that they've checked to reduce risk. And that is just one of many checklists that in the end result in an amazing feat where we can fly passengers around the world in pressurized aluminium tubes without them basically ever dying. To make this more real, let's talk about a real case. So this patient you can follow at Disfigured Beauty, commented on one of my YouTube videos and has an article all about her horrible experience in the Daily Mail. Now what I've learned about this case, although I'm hoping to interview the patient in more detail, is captured quite well in these pictures. This patient was injected with a non-reversible dermal filler, calcium hydroxyapatite. The patient appears to me like they were injected with a cannula, and after the procedure they developed pain and then tissue breakdown over time until they in the end suffered a really horrific injury resulting in loss in a portion of her nose. She now wears a prosthesis to enable her to live a relatively normal life. But as you can imagine, this is still a really difficult situation for any human to be in. And it's cases like this that really drive me to talk about these topics so that other injectors can make better decisions. If I'm correct, by looking at these pictures, you can see the entry point of the cannula. So many injectors believe that using a cannula is almost a black and white way to be safe. And it's very important to see some of these cases that buck the trend because it makes you think harder about other things you can do to decrease risk. Now, what's the issue with a cannula? I believe cannulas overall have a lower probability of vascular occlusion than a needle. It's something like 4 to 5 times safer, which is a fantastic thing to know. But there is a downside with cannula, which I think you can see quite clearly in these images, which is that when you are in a vessel, you tend to stay in the vessel. It's much harder to get into them, but when you're injecting, you tend to put more in one place. By nature of a cannula only having one entry point, depending on where you're injecting, you tend to spend more time in that particular point. This means the size of the vascular occlusion is bigger when you get them, even though it's far less likely that you will get them. Now combine that with the fact that we're using an irreversible product, something that you cannot dissolve with hyaluronidase, something that's also quite thick and stodgy, calcium hydroxyapatite, and very hard to massage. We're actually much more likely to be in a situation where nothing can be done in time to prevent tissue death. This is very similar to what happened to Julie Bass-Kaplan. If you've seen that video, which we'll link towards the end, you can also go through all the different stages of necrosis that happen. Now, it is my humble opinion that this product in particular is overrepresented in the most severe cases of necrotic injury. And it's simply because there is one significant safety feature missing. You cannot reverse it. This does not mean that it's not an appropriate product for some patients, but I would say that it should be a small minority of patients, potentially those who are allergic to hyaluronic acid. Also, don't forget to sign up to my waiting list if you are thinking about joining my movement. If you want to learn more and progress safely, it's the place to be.